So today's talk is on the approach in exanthematous rash in children. My approach, but if you look at a lot of the next few slides, you show that you show that these are the slides that are normally we just copycat from another author. He likes to describe on centrally distributed, the distribution, like the type of rash, and then where is it distributed, and he comes up with illness that are non-infectious and infectious. That's how he describes it. And then there's other things like peripheral disease. So these are all slides that are copied from another author. And you can all, I'll go through the slides slowly, and then so you all can have a copy of the slides when I finish it. And yeah, this time make sure I don't lose the slides like the last time. So these are all things that you can read out about it. But he's interested in the type of lesions, and then of course they went to infectious and non-infectious. That's how he describes it. But everyone has his own way of approaching exanthematous rash. So exanthematous rash means usually it's involved with infection, but sometimes medication can cause as well, and there's also tied up with some connective tissue or diseases, as well as drug-induced as well. So my approach is slightly different from others, but again subject to everyone's opinion as well. So so there are a few topics here. There are 6 topics that I talked about. So the first steps will be the Socrates approach, which I used Socrates approach when I talk about elevated liver enzymes. Then I go through some very typical slides on classical viral exanthems. So SOC, so C is classical viral exanthems, R is the rare exanthems, and then A is a lumps list. Then T for treatment and travel induced exanthematous rash. And then we do a bit of case studies. E is about expectations, and S is a summary of the medical issues. So we start off with systemic analysis. Systemic analysis is basically analyzing the lesions, so macule, papule, nodules, vesicles, and then do a systemic analysis as well. Onset of rash means is history of the rash and the clinical cause and prodromal symptoms, and also for occupation and other medical history as well. So we start off with, so this is what systemic analysis is all about. This is my approach. And the onset, O is also talking about this. Onset and occupational. Okay. So classical viral infection exanthems, basically when the registrar comes to see me about a rash in children, so the first thing I normally scan through is a classical virus, things that have names on it. Sometimes we don't even have a name for the viral exanthem. So measles and rubella almost share the same thing, except that so they go head to trunk to extremities. So I always tell my registrars, okay, tell me about these 4 exanthems, which you should know. You should just go through it. Rubella has the same sort of distribution of rash, so it's head to trunk to extremities, but it doesn't involve the palms and the soles. But the difference is that in measles, they have the 3 C's: the cough, coryza, and the conjunctivitis. And complex, if you can see it, complex is a oral mucosa and is seen opposite the molars. But rubella, on the other hand, has low-grade fever. So measles has like 104 degrees, but this one fever is very low here. But the difference in rubella is they got limb adenopathy on the posterior cervical, which is deep to the sternocleidomastoid, posterior auricular, and suboccipital. In measles, the fever, on the day 4 of the fever, that's when the rash comes on. This one in rubella, it just disappears. Fever is sometimes may even last a few hours, and limb adenopathy is seen, but the rashes are also very transient. unlike the measles rash, and it leaves behind a pigmentation, and it disappears in the site where it comes from, so it disappears in the head and the trunk and then the extremities. Rubella has also Forsheimer, which is the soft, is spots on the soft palate, and it's a non-exudative conjunctivitis. Low-grade fever, that's why the arrow is flat. It can involve encephalitis as well. In measles, they have AED, is acute demyelinating encephalitis, and subacute panencephalitis with the cough and otitis media, pneumonia, and seizures. Rosella is interesting because in a younger age group, but they don't start in the head, but they start on the neck and the trunk, and go on to the feet and the extremities. The fever is very high, so 104. But the typical one in Rosella infantum is also known as the sixth disease, or another one is called Exanthematous subitum. So it's got three names: Rosella infantum, caused by the HHV virus 6 and 7, human herpes virus 6 and 7. The typical part is when the fever disappears, the rash appears. Nagayama is seen apparently in 65% of cases of Rosella infantum during the febrile phase. So it's seen in the uvo-parotid area. There's you can see spots between the uvula and the palate there, and there's cough, running nose, and diarrhea. Erythema infectiosum is caused by parvovirus B19. So this one is interesting because it does cause. There are two types of rashes. So there's fever. Then the first rash comes with a slapped cheek, then goes to a lace-like or reticulated appearance, and the trunk goes to the limbs, and this reticulated is seen the rash is exacerbated by emotional stress, exercise, and also by if it's hot weather as well. And they have a very interesting complication because they get arthralgia, transient aplastic crisis. It's like a shutdown of everything, of all the blood components, and Guillain-Barré and hydroxyurea seen in 10%. The important part is erythema infectiosum. When the rash appears, they are no more infectious, so they are infectious before the rash comes on. And this is a typical macular papular rash. So it could be anything from measles, rubella, centrally thing, so it could be measles, rubella, and it could be any of the others, differential diagnosis as well. And that's complete spots opposite the molar. This is supposed to be rubella, but okay, so it can be measles as well. Rubella is actually now, they say this, they scraped off in America in 2004. They think they eliminated with all the measles vaccine. Measles, mumps, rubella vaccine is 95% effective with the first dose. But in the measles, it's 99% effective. But now they can cause, I guess, if we expose rubella child to pregnant mothers, first trimester, you get congenital rubella syndrome. And the most common thing is a hearing loss. That's slapped cheek. So slapped cheek is seen, is caused by parvovirus B19 and erythema infectiosum. But when the rash appears, the child is no more infectious. So you should know at least about, in KFP, they can ask you like 2 or 3 complications of it. So you get transient aplastic crisis, and so you're able to name a few complications of it with hydroxyurea and miscarriage. And that's the lacy reticulated thing. These are the rashes that are seen on the forearms, and then it spreads to the trunk. So they can be exacerbated by emotional stress and exercise and change in temperature. And that's chickenpox, so everybody knows vesicular rash, centripetal. So CP, remember CP is chickenpoxal centripetal, in contrast to centrifugal. So centrifugal is smallpox, which is no more seen now in the world. The centripetal CP is centripetal. It starts on the trunk. It involves the mucosa as well. Okay, so we finished with a classical viral exanthem. So you must run through your head and you must know this by heart already. These are the ones that are rare ones. So there are 4 mnemonics will help you to remember. Help 2. So H for Coxsackie virus, E for eruptive pseudoangiomatosis, L for unilateral lateral thoracic exanthem, and P for papilla, purpuric gloves, and sock syndrome. And Gianotti cross-T is also known as papilla eruption of childhood. So remember the 4. So the 4 classical, 4 help symptoms, 4 rare symptoms with help. So we'll go through Coxsackie virus is usually caused by A17, but in this case, A6 has a predominantly skin involvement. They involve the skin and they cause separation of the nail plate from the nail petrix, so they call it onychomatosis. Eruptive pseudoangiomatosis is like it's just eruption of papules on the face and the trunk, and it resolves in 1 to 2 weeks. Unilateral thoracic exanthem can also also starts in one area and then goes to the axilla, can be generalized as well, and the rashes last a bit longer, 2 to 5 weeks. Papilla purpura is actually caused by the parvovirus B19 as well, PPGSS. So they, as the name suggests, they got papules and purple lesions, but they are limited at the glove and stocking, so they can be stopped at the wrist, they may stop at the elbows, they may even stop at the knees. So it's a very beautiful picture of it. But this the difference between this and erythema infectiosum, the same virus agent, but at this stage they are infectious. So when the skin rash is seen, they are infectious. In erythema infectiosum, when you see the rash, they're no more infectious. So the same things, transient aplastic crisis, miscarriage, hydroxyurea, the same thing. Papillary acrodermatitis is an Italian name, Gianotti cross-T syndrome. They've got vesicles and they are seen on the face. These are rare ones, but they can cause hyperpigmentation up to 6 months. Kopner phenomenon, are you aware of Kopner? So when you rub something along the lines of pressure, the lesions appear. Kopner is not specific for Gianotti cross-T. Kopner's phenomenon is seen in psoriasis, lichen planus, ectopic dermatitis. There's a few 5 or 6 conditions. Viral warts as well can cause a Kopner phenomenon as well. So that's hand-foot mouth, typical hand-foot mouth, where it involves the palms and the soles of the feet. But in H6, so they have all the symptoms of the A17, that's classical hand-foot mouth. But in this case, in A6, they're predominantly more cutaneous signs are seen. So you get vesicle, bullous, eczema, herpeticum. So a bit more skin signs. So sometimes they are rare, but then it does exist. And this is onychomatosis, where the separation of the nail plate from the nail matrix. It takes a few months for it to come, and it's seen in A6 as well. This is pseudoangiomatosis. You can see papules, just like insect bites. They are also linked to viral infections as well. And you can see there's a halo. I'm sure you have seen this before. There's bacillary pseudoangiomatosis, and they can take, even if it's symptomatic control, but they can disappear on its own after a certain time. Unilateral thoracic exanthem is where they seen macular papilla seen on one area, then it spreads to involve it usually starts at the axilla. It can start in the inguinal area as well, but then it spreads to involve the trunk. This is the PPSG that I'm talking about. PP, this papilla, the glove and stocking. You can see that papilla, and there's a cut off, a demarcation point here at the knees. So this is also caused by parvovirus B19. And see that? So they are limited to up to the knees. And this is Gianotti cross-T, so vesicular lesions with Kopner's phenomenon. also linked to viral infections. You can see the vesicular areas with papules as well. And face and the trunk face and the extremities are the common areas involved. Okay, now, so we finished the classical virus, then we run through the rare exanthems, then the alarm list is the most important. So A, L, A, R, M, and then the S. So there are a lot more S's. So it can be in HIV, but of course with children, it's probably is a macular papillary. So central macular papillary, measles, rubella, acute HIV, it can be a possibility, but acute HIV is probably seen in some areas that are in children which are endemic. And these are, yeah, in HIV, acute HIV is like after fever, then of course with sore throat and all this, 2 or 3 days later, they can have lesions of the face, scalp, and extremities. And they can have rare lesions apart from macular papillary, they have vesicular, pustular, and urticarial eruptions. So leptospirosis I didn't have. So A for HIV, leptospirosis I didn't describe. I didn't have these slides for that. Avasculitis, another name is also called as Henoch-Schönlein purpura. So this is a new terminology. Henoch-Schönlein is an old terminology. Mean age is 6 to 7 years. They usually come in this, but they can come in order of presentation. So the most predominant sign is purpura with arthritis. But sometimes the child may have abdominal pain with arthritis without a purpura. It will be difficult to make a diagnosis of IgA vasculitis with just abdominal pain simulating appendicitis or abdominal colic, unless you see the purpura. But the purpura, when you see it and you can feel it, but it doesn't lunge on pressure. When you do a full blood count, the platelet count is normal, and your coagulation profile is normal as well. And this is other areas where you can get purpura. So A, L, A, and then R for rickettsial. So rickettsial, Americans have their rickettsial mountain spotted fever. Malaysians, of course, Southeast Asia, they have SCAR. These are called what? Scrub typhus, Sutsugamushi. Rickettsial, Sutsugamushi. So you can see it's bitten by a tick. So the tick, so in the Malaysian one is a mite. So this is caused by a tick. In Australia, it's a Australian Australis, Rickettsial Australis. And you can see there's a plug, but here there's like a cigarette burn appearance, or call it as an scar. And these are the tick that is not bitten, but once the tick is fed, it becomes like almost like 20 times the size of a fat tick. I mean, a hungry tick that's not fed is host. And a lot of Australians, they like to go bushwalking and rural areas. Very common on the eastern areas, not so much on the western areas. You can see the big strip here. Also, they call it Queensland tick typhus. But along the strips here, you can get, if there's a tick bite, there's a chance that you can get with Australian tick typhus or Rickettsia australis. How do you treat it? So it's a bacteria, so it treats, I don't know, your response to tetracycline. So tetracycline, doxycycline rather. So you take doxy, you're supposed to take it on either empty stomach and of course cause gastritis. Try to avoid milk, because milk chelates the doxy, prevents its absorption. If there's contraindications, then they put them on azithromycin, but they're all a week. So yeah, they probably rickettsia, I don't know, microbiology, whether they have a cell wall. They probably don't have a cell wall because doxycycline usually acts on the ribosome synthesis, if you remember your pharmacology. So 2 to 14 days there is an scar, and then the bite. The scar is at the site of bite about 2 days after. Incubation period is up to 2 weeks. Then the other R is something. Sometimes we have to be able to diagnose infective endocarditis, a patient with infective endocarditis, and we use the Rose J signs in bacterial endocarditis. So Rod spots are very specific for IE, but they are exudative hemorrhagic lesions on the retina. RO is Osler, Janeway, and conjunctival hemorrhage. So rod spots is another, the Ross J signs is another sort of, we call it as a Exanthematous as well. So there's a flame-shaped hemorrhage, and then right in the center, there's a white spot. So it helps us to do blood and culture to rule out infective endocarditis. And you can read about all this in the notes later. These are all slides that are taken. So okay, we move on, and then splinter hemorrhages, yeah, in the nail bed, but it's not specific. And then it goes to, so ALA, so A for acute HIV, L for leptospirosis, A for IgA vasculitis, R for rickettsial and the Ross J signs. Then we go to M, so meningitis. So when we do meningitis, I always see my students or registrars, they come fever, so they do a Koenig sign. So how to remember? KE, knee extension is painful, Koenig. Rustinsky's, you neck flex it, and it causes knee flexion. And then, of course, there's rashes. So there's there are 3 types of rashes. The rashes can be macular-papular, resembling rubella. See that? It's transient. So there's early finding in meningococcinia. And also petechial rash are seen on the trunk. And this is the late stage where there's popular fulminants. But the most important signs suggesting early sepsis, these are the most important questions if you suggest meningitis. Leg pain occurs apparently up to 75% of patients. The difference between cold hands and feet and abnormal skin color occurs up to 25%. They say if you have any of these 3 signs, you may be dealing a case with early sepsis and meningitis. The problem with meningitis is that we don't see them nowadays. As a general practitioner, we don't see them because we don't see enough to be able to diagnose. Number one, and number two is that because of our good, our vaccination program, we don't see a lot of meningitis nowadays. The second thing is that they progress very fast. So between this and the meningeal signs is about 9 hours. So once the meningeal signs come in, another 2 hours they come up with rashes, and then it's too late. So most of the patients presented late to the hospital. These are the 3 questions that you should ask if you're suggesting a sepsis. And this is early meningitis on the hands. And this is so within very fast they progress to purpuric spots, and these are of course very late stage. And this is like necrotic gangrenous hair. This is the purpurar fulminans, which is seen in the later stages of meningitis. And then miliary tuberculosis is another one that you can get macular papular thing. So this is the other M. So the M for meningitis, M for miliary TB, and then you get pink lesions, and they can get macular papular and as well. But yeah, so this is miliary TB that can be seen as well, but of course it's not so common in our country. Neither is it common in Malaysia. And these are the ones that I'm interested in. So because now SARS, COVID-19, and so mucosal lymph node syndrome is the old name is Kawasaki. I have a case study to do it at the end of my talk. So I'll talk more about Kawasaki later on. But Kawasaki has a few things that has a very close resemblance to SARS-CoV-19. They call it as MIS-C, multi-system inflammatory disease in children, which is seen about 6 weeks after SARS-CoV-19. So this is COVID-19. So we start with COVID-19 because COVID now is still a pandemic in the world. So we have mild, moderate disease. It's seen COVID skin. You can see up to 20% of patients with COVID, with SARS-CoV. So it's not rare. It's common. But they're still studying. A lot of people are still studying, and we're still reading about new things in dermatology in COVID. the three common things that are seen with mild moderate disease is a chilblain or acral lesion. So we call it CLL, chilblain-like lesions. It's not chronic lymphatic leukemia, it's chilblain-like lesions, seen in teen children and more in European, so you may not see in the Asian population. The painful lesions, and they are exanthematous or pink or violet color, very mild. Urticaria comes and goes, and also mild, and vesicular eruptions are most often the hands or trunks, but they're medium COVID. So these are the things that you see. So this is COVID dose. So these are the ones that are mild lesions. And urticaria, it's just like an acute urticaria. And vesicular eruption. So these are all the mild ones. The severe ones will be the severe disease. So if you see a macular papular eruption, it is severe in COVID. It carries up to 2% mortality, mostly on the trunk. There's another one called retiform purpura, which occurs in 6%. So they are purpuric, but they are violet, so they are net-like lesions, and they're very severe COVID, more in old population. And these are the ones that we probably need to discuss later on when we come to Kawasaki. So Kawasaki is 5 weeks, 5 days of fever with conjunctivitis, and also with mucositis, mouth, and then the rash, then followed by edema, hands, and also peeling of the fingers. Male pattern baldness also apparently also have increased hospitalization. Post-COVID, you can get exacerbation of your atopic dermatitis and psoriasis. You can also get in post-COVID pityriasis rosea with the harrow patch and the inverse Christmas tree appearance. You can see in COVID as well. So these are very interesting new things. Macular papular eruption. These are seen in severe, and same with the net-like retiform purpuric lesions. Male pattern baldness. This is alopecia areata, so it's not male pattern. So this is seen in conjunctivitis. They are also seen in COVID-19 patients as well. It takes about a few months to recover. So this Kawasaki, so the rashes are edematous. The most common thing, the most important lesion to ask is where did the lesion start? So the lesion starts from the anal area. So you must always remove the diapers, check. So you ask the mother, where did the rash appear? So it appears in the diaper area, then it progresses towards the other parts of the body. You can see the child has mucositis as well, in addition, and conjunctivitis, and edematous lesions. Then we just run through scarlet fever. The S's are all the S's. After the M, the S for scarlet fever with a strawberry tongue, and scarlet fever and Pasteur's lines, and yeah, these are all the and then we talk about toxic shock syndrome. The strep can cause toxic shock as well. Then Steven Johnson is not only involved, but involves the mucosa as well. So this is one of the skin emergencies, and usually it's drug induced. But if you see Steven Johnson is erythema multiforme, and if we had to list, like in the KFP comes out in the exam, list 3 causes, then we must think of mycoplasma. And then secondary syphilis seen probably again, not so more in the adolescents with involvement of palms and soles. Typhoid, I put it in because salmonella typhus. When I was a medical officer or in hospital Bahagia in Tanjung Rambutan back in the 1980s. So there was a patient that came in, and then he climbed the walls. He's signed up as mentally unwell. They thought it was schizophrenia. I was on call. I went in and I saw him with high fever, climbing the wall. So we got him down, examined, and we saw rose spots. So rose spots are between the nipple and the eyelid crest, and it's one of the symptoms. I was lucky enough to see rose spots, the macular papular. So it's one of those things that we see in the tropical countries. I was fortunate to see that rose spots. And then subcutaneous, this is again can be seen in exanthematous, also involved the SLE as well. Then acute, subacute, and chronic. And the butterfly-shaped rash that involves, it spares the nasolabial area in mala rash. And then after all the S's, then we get treatment induced. So T for treatment. So treatment is like, these are the patients that they got EB virus, and we started him on amoxicillin, and you can see that 95% have got macular papular rash. So this is one of the drawbacks of starting antibiotic in a sore throat. Because if you look at the sore throat, this is streptococcal infection, and you see that there are exudates on the tonsil, tonsils are enlarged. But we look at EB virus, not much help. They also exudates, they are there. So you really can't differentiate, And sometimes we are pressurized to start antibiotics. So there's petechial hemorrhages here, petechial spots on the palate. There's not much of difference between, see, this and this. There's not much of difference. So I made up this table about, I don't know, 15 years ago, I think I made this up. and I said that the lymph nodes I would like to share with you. So this table, you can have this table, which I created about 15 years ago. And you can see the lymph nodes in EB, like posterior triangle. And then you can see parietal petechia, they are more seen in EB than in streptococcal. Apparently, they have more periorbital edema than streptococcal. And splenomegaly, of course, they can 50% and then peak second week. So they tell them don't play contact sports for 3 weeks. Contact sports, then you get a splenic rupture, which is abdominal pain and decrease in hematocrit, which is diagnosed by splenic rupture. Hepatomegaly, not so common, but also seen in 90 to 15%, 10 to 15%. Rashes, you can see in children, but you can also amoxicillin for macular papular rashes, but you can get it with other antibiotics as well. So it's not just amoxicillin. You can get it with cephalosporin. You can get it with even other antibiotics, cefalexin as well. Although amoxicillin is the most consistent or most commonly causing this. So if you have to start antibiotic for tonsillitis and you're not sure, try not to start amoxicillin because it can create these sort of issues with it. So this, I think whether this table may be helpful for you to want to look for other things, other signs, because the throat is really not much of a help to differentiate. And these are the petechial hemorrhages on the soft palate, which you are supposed to see in EB virus, but you don't see in streptococcal infections. And periorbital edema, not so common, but EB virus is a bit of swelling of the eyelids. You can see that as compared to streptococcal tonsillitis, they shouldn't have. Then this is an interesting thing because this is a new bacteria. So Arcanobacteria is new because I did a microbiology degree before I did a medical degree. And when I did microbiology back in the late 70s, so we don't have heard this bacterium, so they call Arcanobacterium hemolyticum. It comes in adolescents. You can have the same thing as any group A and virus associated. So they have fever, lymph nodes, they got a rash, and you try to culture, they don't show anything. But this is something new, so they are susceptible to erythromycin. And the rash can be itchy as well on extensors, and especially spares the face. So there's something new for you to think about in Arcanobacterium hemolyticum. Okay, so T. So T for that. So treatment, what are the treatment involvement? So treatment, so drug rash is common. So drug rash is not common, but it occurs about 2% who are given medications. Because first you have to differentiate, is it Stevens-Johnson? So you check the mucous membrane and make sure the internal organs are spared. They can have macular exanthems, or you can have anaphylaxis as well. The most common culprits are antibiotics and anticonvulsant. If you have never had it before, then it takes about 1 to 2 weeks before the rashes come on. But if you have been sensitized, the duration is shorter, so 6 to 12 hours. Okay, this is so this early onset, there's macular papular exanthems in red. But then there's another one called SDRIFE, so symmetrical drug-related intertriginous flexural exanthem. So they involve the intertriginous areas, so the axilla, the groin, as well. So there are flexural areas involved, symmetrical drug-related. So these are common. So there are, so the number of days, say about 5 days, and then it drops down to 8 days, it disappears. So about the same time, you can have both common drug reactions. And normally we stop the medications, then we can, I mean, there's two schools of thought. It's a gray area, but normally I mean, apart from symptomatic control with antihistamines, we also put, sometimes we put oral prednisolone as well, up to about 1 milligram per kilo. So it helps in the thing up to about 7 days, unless it's diabetic or any contraindications to it. And these are the other skin things that the drug eruptions can occur. So these are important graph to look at. And it's important that these are the two common drug reactions. So when I did immunology, my first did immunology, when I did microbiology, we had type 4C, but now of course we got type 4, got A, B, and C, and D as well. So whatever, for those who are in immunology or love a bit of immunology, macular papular actually belongs to type 4C. So asthma is type 4B. And so there's a lot of research, a lot of things that have progressed on with as in all aspects of medicine. So I look at this, I was very thrilled with it, because I was thinking about my immunology was a bit backdated, and I wanted to read more about this. So we are with the drug reductions, we are type 4C. We did type. So we did, so we finished everything. So basically my approach is like we do a systemic analysis of the rash, the Socrates approach. Then we do an onset, where we talk about the chronology of the clinical cause of the rash alongside with other symptoms. Then the C is the classical. So I would like to normally flush through the classical those exanthems with names, with viruses, because infections are common. So I'll just go through it with my registrars and say, okay, tell me about measles and rubella, tell me about erythema infectiosum, tell me about Rosella infantum. So they should be able to like boom, 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 and everything should be just at their fingertips, just to remind. Then the rare ones, I don't expect them to know, but then the rare ones are rare, but then it's good to know. So they got the A6 of the thing, H, the help, HELP, E for eruptional pseudoangiomatosis, and then L is the lateral thoracic, unilateral lateral thoracic exanthem. And P, there are two P's. So there's the PP, the papular syndrome, the glove syndrome, and also the genital crusty, is a papular acral with the Kopner's phenomenon. And then we talk about so SOCRA, then T for A is the alarms list, which I go through the alarms list, ALARMS, and there are so many things that are there. A for acute HIV, L for leptospirosis, isn't it? A for IgA vasculitis, R for rickettsial infections, R also for Ross-J for infective endocarditis, then M is meningitis, things like that. So then M also for mucosal lymph node. With COVID is drawn in as well, because COVID has a thing similar to Kawasaki called MIS-C, multi-system inflammatory syndrome of children. So seen in children, but usually 6 weeks after COVID-19. Then you must know the mild, moderate, or the severe COVID infections. Their skin up to 20% of COVID. And then they talk about Kawasaki, we should know about Kawasaki, any child with fever, which is this case, which I'm going to talk about it. It's an actual case study that was done. And also, and then a lot of S's after S's is scarlet fever, and then streptococcal toxic, staphylococcal, SLE, the other ones with typhoid, salmonella infections. So there are a lot of S's there. Okay, so we go to this case study, which is the actual case study that was seen. So this child, the name is AB, so she was 17 months. So she came with her mother on the 16th of September 2019. So mom said, is quite sure, mom said the fever 5 days. So what stirred on the fingers? Oh, mom said 5 days, has to be looking for Kawasaki. I still went through the classical viral, I still went through it, but then she was not on any medication. So she had upper respiratory, she had cough, and she had rashes for 4 days. But I asked them to take off the nappy, and there's a nappy area had the rashes. Then they said, the mom said, the nappy area no more rashes. But then when I saw the rashes was up to the legs, then the back and arms and the face, and she's not allergic to anything, immunization up to date. Examine her, cracked lips, congested pharynx, red eyes are bilateral, she had bilateral submandibular lymphadenopathy, the chest was good, heart sounds are normal, abdomen is soft, ear is a bit congested right side, left ear is clear. So then I told mom, I said, look, this child is a case of fever for 5 days, and she's got red eyes bilaterally. And in Kawasaki, when you look at the red eyes, they are non-exudative, but they don't affect the limbus. So the limbus of the eyes, the perilimbal is not affected. So they're bilateral, they're non-exudative, and they don't involve the limbus. So you got a tick in the box for red eyes. The lips a bit cracky, like moist lips, but open the mouth, congested pharynx. I didn't see the strawberry tongue, but look for it, couldn't find it. So you got 2 points there. Then you got the rash, which is classical. The rash came. This mandibular lymphadenopathy is not significant because it has to be 1.5 centimeters big, and it usually comes later. The cervical lymphadenopathy. And the cervical lymphadenopathy, the 1.5 centimeters, is the most inconsistent sign seen in Kawasaki. So fever is not criteria. Fever is not among the 5 criteria. The fever must be there. So there must be fever, and then you look for the 4 things, 4 out of 5. I had only 3. I got red eyes, I got cracked lips, I got a rash. And so she comes under what we call as an incomplete Kawasaki. So incomplete means it's not complete, as the term suggests. So if I send to casualty, they probably knock it down and said, oh, send home. So anyway, mother wanted antibiotics, so I didn't give her antibiotics. So she was a bit upset. She went home, just like, all I wanted was antibiotic, but anyway, she left. And so this is what I said, a non-exudative. So the perilimbal is spared. Can you see it? Perilimbal. So these are the limbus. There's conjunctivitis here, but no exudates, but the perilimbal is spared. So these are very classically seen in Kawasaki. They're not exudative as in conjunctivitis. This is convex. You can see the cracked lips and the mucositis. The tongue. And this is typical strawberry, but this also strawberry can be seen in scarlet fever. So any of those mucositis, she had cracked lips, and this is another mucositis involvement as well. So she went to emergency. So after she saw me, she went to emergency. So emergency, sometimes they have junior doctors, or I don't know whether so they send her home. They say it's hand, foot, mouth. I don't know how they reach hand, foot, mouth, because the hand, foot, mouth, they should have vesicles in the mouth. So when you see vesicles, it's not hand, foot, mouth. And you see purpuric skin lesions, it's not hand, foot, mouth. When the child responded to antibiotics, it is again not hand, foot, mouth. Okay, so these are the things that you must understand. if you have vesicular lesions, purpurate lesions, and the child responding to antibiotic, it is not Kawasaki. Kawasaki is a medium inflammation of the medium-sized vessel. So it's a medium-sized vasculitis. So it should not respond to any antibiotics. The fever will still be spiking and spiking. And then, of course, she called up the doctor. Mom called up the doctor. In Australia, we have this like 24-hour emergency doctor. They go to your house and see you, and it doesn't cost you any money. It's just all with the government. So and when they started, and then she gave antibiotics. She gave antibiotics, but then the child still didn't respond. But I educated the mother. I said, look, if you see disquamation of the fingers on day 7, swelling of fingers, then we got a full classical Kawasaki. And mom remembered. So on the 28th, this is how many days later, edema, both with disquamation. There's something like, the first day is the fever. So she came here 5 days of fever. So this is like probably what, 19 days now of the thing, of the fever. And then, so mom came and sat in front after going through doctor shopping, like a few doctors. So she sat in front of my room. So I opened the door, I saw her, I knew what she wanted. I said, now you believe me. I said, I've been crying, wolf, wolf, and now you believe me. I said, because the wolf came. She said, yes. She said, I shouldn't have doubted you. So this was Kawasaki with us, and yeah, so this is how you differentiate from the rest of the, so they are usually less than 5 years, the persistent high fever. And streptococcal, you can still get strawberry tongue, but the age group is higher. Fever comes down, see that? But the fever here is still spiking because of the arthritis of it's a different pathology, it's a vasculitis thing. This again is autoimmune, so it's still spiking. With Steven Johnson, yeah, it's the drug thing. So it's a different response. These two, the fever comes down after 10 days or so. And streptococcal scarlet fever, you don't have conjunctivitis. But you can have a strawberry tongue. So these are things to differentiate. Kawasaki, yeah, so these are different signs that you can think of So anyway, this child was then, I refer her to casualty, so that the child they took out. So I wrote a very definite letter, and I said, is the child, so I put down all the points and I sent it to them. And then now they call the head pediatrician to come because this one got enough evidence now. So no more junior doctors in. So then they admitted the child. They gave here IVIG, intravenous immunoglobulin, because they can get coronary vasculitis. Apparently, they say that the coronary vasculitis occur as early as 10 days after the thing. So it started, so they gave, anyway, they gave it 10 days later, even it's 19 days, they still give the IVIG because there's no other treatment. They can give aspirin, I guess aspirin until, aspirin can cause Ray's syndrome in children, as you know. But then they give aspirin, I think 3 to 5 milligrams per kilo. They check the echocardiogram and then they found that it's good, so they stopped the aspirin, but they given the IVIG. And when you give IVIG, when you vaccination, like live vaccine, you must wait 11 months. So 11 months after the IVIG, only she gets her chicken pox, because she was 17 months when she came. So her chicken pox and measles, mumps, rubella vaccine had to wait until 11 months after the IVIG. So that was how we treated the Kawasaki. They are rare, but then you can still see it. You must retain, you must exclude. So it's not, it doesn't look like the typical ones, but it, and now with MISC, with SARS-CoV-19, they can cause a similar presenting thing. But of course, there's no COVID. With Kawasaki, you don't have a COVID. But fortunately, at that time, 2019, there was no COVID-19, so I didn't have to do any tests to exclude SARS, the COVID-19. Okay, so this one is it wasn't hypothetical, but I'm going back to Malaysia at that time when I remember this case, but obviously I had to recollect and rewrite this whole thing again. I remember there was a 13-year-old boy. I was a village general practitioner in Parit Buntar in Perak. And then this patient came with high fever, joint pain, 3 days, and he had rashes in the trunk, macular papilla, and non-pruritic and non-branching. But so it could be anything. So it could be a viral infection. It could be otherwise asymptomatic. So they came with rashes and fever and joint pains. But when I took the pressure, so what I'm trying to emphasize here is the blood pressure here. What's wrong with this blood pressure? So this is the difference of the systolic. So the systolic is a maximum pressure when the heart contracts in systole. And 90 is the diastolic, so the maximum pressure when the heart relaxes in diastole. When the heart relaxes in the diastole, that is called the diastolic pressure. So in this case, the systolic pressure is still normal because it's 110 is still normal for a 13-year-old. But the 90 is the one where the body tends to throw up catecholamines. So it's called like a physiologic decompensation. They're trying to maintain the pressure. Then they push it up, the diastolic pressure. So although the systolic is normal, this is the pulse pressure is important. So the pulse pressure here, in this case, of course, the systolic is low, like less than 90, is definitely significant. But in this case, the systolic is normal. But the diastolic, the pulse pressure is 20 or less. So this is called is significant finding because it means that the patient, if they are having dengue, because at home is dengue, or even if it's macular papillary rash, it can be dengue in the febrile phase. They are not purpuric. So this defervescence happens on the 3rd to 4th day, and they can last in 2 days. So the child obviously had to send in because this is like a vascular leak syndrome at that time. So this initially they can have this macular papillary rash. But the most important thing is you must monitor. Those still practicing in tropical countries, but dengue is still predominant in. There's called in Queensland and all that. So apparently the head of the tropical school in infectious disease is actually my classmate when we studied tropical medicine in Bangkok in 1986. So Dr. John and I were classmates when we did tropical medicine training together in Bangkok. So he sees a lot of these dengue cases. So when you do this, and you must do the blood pressure. And the blood pressure, if the pulse pressure, you must look at. Systolic pressure is low, less than 90, is something is a bit funny already. Pulse pressure, even 20, the difference between systolic and that's what it's called pulse pressure. And this is the convalescent phase, which is the febrile phase, then the critical phase, and then the convalescent phase. So the convalescent, the critical phase is the one that has no rash. Or sometimes intermediate, we are trying to move from febrile phase to critical phase. So you might be seeing the rashes fading out. Then convalescent phase is when you see the islands of white in the red. So this is a very beautiful picture in the confluence. But in the critical, so what I'm trying to take home message that people must understand that you must take the blood pressure, and if the pulse pressure is 20, exactly 20 or even less, you admit the patient because it's a vascular leak syndrome. And you're going through a critical phase, or you're not supposed to see a rash, but you may be at the phase where it's moving from a febrile phase to critical. So I think these are the 2 case studies. So I'm basically sharing my experience with you and telling my approach. It may not be the best approach, but you share, and then hopefully we still learn. We continue to learn even at my age. We still learn and we study. And thank you